Good evening, everyone. My name is Dr. Satish. I work as consultant at Yashoda Hospital, Secunderabad. Today, I'm going to moderate this webinar session, Pep Talk. Every Friday, Yashoda Hospital Emergency Department comes up with an interesting topic. And today we have with us one of the eminent emergency physicians of Hyderabad, Dr. Naveen Nimala, who's the group head of the emergency department at Sri Sri Holistic Hospitals, to give a talk on post-exposure prophylaxis. So I would request Dr. Naveen Nimala sir to take over and go ahead. Thank you, sir.
Thank you, Dr. Satish. This is chosen as a topic basically to educate people on what kind of tetanus to give and to prevent the abuse of tetanus. See, most of the people still keep giving tetanus at every injury. So that needs to stop, and what kind of tetanus shot needs to be given. We'll also be looking into rabies prophylaxis, hepatitis A, B, C, and HIV post-exposure. So all those we will discuss in the next 30 minutes. So let's start with the tetanus vaccine first. So coming to a scenario, this is what we encounter in our EDs. Like say some 7-year-old boy come to our ER with the rusty nail injury. So he accidentally got onto the wall and the wall had a rusty nail. So now the school teacher obviously brings the kid to our ED. So now the initial question will be like, do I need a TT? Shall I get a TT like that? So at this point, what do we do? Most of the people, in fact, they buy the vial themselves and they come to our EDs. So at that point, we simply give it off most of the times. So the tetanus protection is offered in many different forms. So it's available either as DT vaccine covering both diphtheria and tetanus, and deep tap, that is diphtheria, tetanus, pertussis together, tetanus and diphtheria TD vaccine, and Tdap, that is tetanus, diphtheria, and pertussis together. So it's available in many forms. So coming to Indian Academy of Pediatrics, they prefer the usage of Tdap or TD in older children and adolescents to maintain both diphtheria and pertussis control along with tetanus. So coming to the cost, if you choose TD, TD is available in most of the pharmacies. It costs about roughly 15 rupees per vial. That's it. The ampule is just 15 rupees. So better we choose this and stop giving plain tetanus. Don't give plain tetanus from now on. If you're having old stock in your pharmacy, ask them to get rid of it and always bring only TD form, not plain tetanus. If a vaccination is pending on the kid, they can go for Tdap, but this costs about 1,500 to 2,000 rupees, depending on which brand it is. So better we reserve this for those who need protection from these, but otherwise we can blindly go for TD. Again, only if they need it. So as per Ministry of Health and Family Welfare, so we have this schedule for India. So in this, pentavalent vaccine is given at 6 weeks, 10 weeks, and 14 weeks. So ideally, whenever you start, you should have a gap of 4 weeks between the dosing. So pentavalent is obviously, as the name suggests, it has 5 components in it. So diphtheria, pertussis, tetanus, hepatitis B, and H influenza type B. So these 5 are together given in one shot. That's a pentavalent vaccine. Apart from that, we need some boosters. So booster first one comes at 6 to 24 months. That is DPT booster 1. DPT booster 2 at 5 to 6 years. That is just before preschool, we say. 10 years, tetanus and adult diphtheria, TD. So 16 years, again TD. So once we take about 6 shots of this, we are supposed to be having protection for our life. We need not give more doses. So the 3 doses that were given as pentavalent. They are called primary series. And the booster doses were given. So 3 plus 3. So throughout life, we are supposed to have protection. So we need not give more doses. So ideally, there should be at least 4 years gap between booster doses. So 4 weeks of gap between primary series and 4 years between booster doses. So during pregnancy, that is either at delivery or immediately after delivery or before delivery, sometimes we give to the mother. So neonatal tetanus can be prevented by immunizing women of reproductive age with TTCV either during pregnancy or outside the pregnancy. So which kind of wounds need tetanus prophylaxis? So ideally, anything that is acquired outdoors that goes deep with contaminated environment. So like soil, dust, manure, sewage, all these things. So most of the things people, at least in India, think that if something is rusty, that causes tetanus. So rust doesn't have anything to do with tetanus. So it's the soil that is contaminating anything. So if that same rusty nail is in the ground, like in a mud or something, then that becomes a risk. So anything that allows Clostridium tetani spores from soil or organic matter to survive and germinate. In case of low oxygen, necrotic tissues, any tract that is deep that facilitates their growth, all those things, we call it as tetanus prone wounds. So in this, there are some wounds that are considered as high risk. So any tetanus prone wound with heavy contamination by soil, manure, or similar material, with extensive devitalized tissue or overt necrosis, burns that need surgical intervention that is delayed beyond hours from the injury. Tetanus prone wounds in patients with systemic sepsis are significantly immunocompromised. In them, we call it as high risk situation. So in them, we have to give something called as immunoglobulins. So immunoglobulins are given for immediate protection, whereas vaccine we give to develop protection in the body. So depending on whether it's low risk or high risk, you take a call on whether only vaccine is sufficient or immunoglobulins are also needed. So coming back to our question. So 7-year-old boy had an injury because of a nail that's in the wall, which is rusty. So at this point, you're supposed to ask for the kid's vaccination history, whether the kid has been vaccinated properly as per his age or not, we need to see. So if someone has completed their primary series and last tetanus dose was less than 10 years ago, no vaccine needed for minor wounds, clean minor wounds. If it's a high risk, you can give a tetanus dose, not plain tetanus, TD, you give tetanus and diphtheria together. And if 5 years or more has taken place since the last dose. If you don't know the vaccination history or they have taken less than 3 primary doses, then you can give 1 dose of vaccine immediately and immunoglobulin only if it's a high risk tetanus prone wound. So the schedule the remaining TD doses to complete a 3-dose primary series. So that is 0, 4, 6 to 12 months. So this is the dosing that we need to complete. So between primary, we need to have a gap of 4 weeks. For boosters, 4 years. Coming to our second vaccination, we deal at emergencies, that is rabies vaccination. So whenever someone is at high risk of dog bites, so someone is working in a facility where dogs are being taken care, like veterinarians, animal handlers, lab staff. So all those people are at risk. So even before they get a dog bite, they are supposed to get protected with pre-exposure vaccination. So for pre-exposure, we give 3 doses, 0, 7, 21 or 28. So first 2 are constant, third one changes based on your country's guidelines. So you will either give 1 IM dose in either deltoid or anterolateral thigh in small children, or 0.1 ml intradermally. So as per recent guidelines, intradermal elicits better response than IM. So WHO seems to be pushing for intradermal dose. Though it requires less dose, the immunogenicity is better. So after pre-exposure prophylaxis, if they somehow get exposed, so some dog bite happens now, as they are already given vaccine, their body knows how to produce antibodies. So in them, antibodies are not required. Now you only give 2 booster doses on 0 and 3. So today and after 3 days. So for any new bite or new exposure. So if someone has completed their 3 doses of pre-exposure vaccination and now they got a fresh bite, they need only 2 booster doses, not the entire course. And immunoglobulin is not required no matter how serious the wound is. Coming to post-exposure, this is most of the population belongs to this category. Like we do not majority of people will be taking the pre-exposure prophylaxis. So most of them come to us to the ED with dog bite. So after a dog bites, normally this rabies vaccine virus is supposed to stay in the saliva of the dog. So we are supposed to wash it thoroughly. So almost 15 to 20 minutes, we have to wash it under continuous running water with soap so that the virus, if it's in the saliva, that gets washed away. And we can apply something that is virucidal, like povidone iodine, or if you have anything else available in your AD, you can use it. So coming to exposure types. So there are 3 types of exposures, like category 1, 2, 3. In 1, the skin is intact. So the dog has licked the skin or something. So in such case, there is no breach of skin. So vaccine and a skin breach is not there. So no vaccine is required. If reliable history and no skin breach, in that case, vaccine is not required. Immunoglobulins are also not required. Category 2 is minor scratching or abrasion. Here the skin is broken, but you don't see any tinge of blood. Just there is a crack on the skin, but bleeding is not there. In such cases, they don't need immunoglobulins. Vaccine is sufficient. Category 3, these are transdermal, means the skin is broken completely and you see some blood coming out. So in that case, you call it as category 3. And whether it's a dog or bat, they need both vaccine plus immunoglobulin. So this is a chart given by the WHO as per 2024 guidance. So in this, is the animal mammal? So in that case, if it says no, species is not susceptible for rabies, so nothing is indicated. Just wash the wound and that's it. If the animal is mammal, is it a rodent? So rodent rarely transmits rabies, so again, only washing is required. If mucous membrane is involved, so in that case, if it says no, then is it skin? If it's skin, if it's not broken, then it's called as category 1. Just washing is enough. So animal licks on intact skin, touching or feeding the animal. Now, if the animal is bat, then whether the wound is bleeding. If it's not bleeding, then it's called as category 2. So if the patient is immunocompromised, you give immunoglobulins plus anti-rabies vaccine because the patient is immunocompromised. If not, then ask the patient whether they have taken any rabies vaccination in their life. If the patient has already completed 3 doses of pre-exposure prophylaxis or post-exposure prophylaxis less than 3 months ago, then nothing is required. Just wash and leave. If the patient did not complete it under the 3 months, then we give vaccine plus wound washing. Then you go for risk assessment. Risk assessment will be shown in the next slide. So if the patient has never been vaccinated, so you have to wash the wound and give vaccine and look at the risk assessment next. So this is for category 2. Now coming to category 3. So if mucous membrane was involved and that is contaminated with saliva, and then if the skin was broken, again it comes under, whether it's an animal bite, that is bat involved, or the wound is bleeding. In such cases, everything comes under category 3. If the patient is immunocompromised, we give wound washing, immunoglobulins, and rabies vaccine. If the patient is not immunocompromised, ask their history whether they got vaccination before. If it was within the last 3 months, then nothing is required. If not, you need one more dose of vaccine. If they have not been vaccinated any time before, check if it's available, like your pharmacy or hospital is having a stock of immunoglobulins. If available, then check patient whether it's high risk or low risk. So risk, if it's high risk, you give washing, immunoglobulins, and vaccine. If not high risk, then just washing and vaccine. If you don't have the stock of immunoglobulins, then washing, and then not available in the sense they are limited quantity. So you cannot just waste the dose on somebody. In that case, you can give it. If it's limited, you check the risk, give it to only high risk patients. If it's not limited, you have a lot of stock available and the stock is not the criteria, in them you can give vaccine plus immunoglobulins. And how do we do the risk assessment? So coming to risk assessment, so did the exposure occur more than 10 days ago? So if the dog bite occurred more than 10 days ago, then you have to observe the animal. If the animal is available, if it's still alive, that means the dog is not infected, nothing is required. Or if you have given 3 doses already, you can skip the 4th and 5th. So normally, the rest of the doses need not be given. If you don't know whether the animal is alive or not, you cannot observe it. In that case, you check whether the victim is high risk, like less than 14 years, multiple deep wounds have been there, and they have highly innervated areas like face and all. So in such cases, you give the post-exposure prophylaxis. This is high risk criteria applies only if your stock is limited. If it's not the case, now ask whether the animal has been tested or not. If the animal was tested positive, you start the prophylaxis. If it's inconclusive or test is pending, start the prophylaxis. If the test is negative, then you can stop the exposure prophylaxis if it's been already started. If you don't know whether the animal is negative or not, now observe if there are any signs that are consistent with rabies. So how does it appears? So rabies, the animal appears like you will have different things coming in. So patients with multiple wounds, deep wounds, bites, highly innervated parts, such as head, neck, face, genitals, and hands. So in this, you will look at the animals. If they're healthy 10 days post exposure, they present no risk for rabies and PEP is not indicated. So the infectious period of other animals is not well characterized, and more conservative 14-day period observation is recommended. So how do you know whether the animal is infected or not? So The hydrophobia that we see in humans is not a sign of rabies in dogs. You may not see that. But animal can have hypersalivation, paralysis, lethargy, unprovoked abnormal aggression. Means it can go on biting multiple people in a single run. So biting two or more people or animals or some objects. So abnormal vocalization, it's barking abnormally, diurnal activity of nocturnal species. Some dogs are supposed to be active only in the nights, but now they are active in the daytime. So all these are signs of rabies in that animal. So in that case, so animal has bitten two or more animals. If it's yes, check whether the animal is alive. If you don't know, start PEP. If the animal is up to date on vaccination, so if it's a pet dog and all, then was the animal exposed to rabies risk in the 12 months? If it's yes, then you can delay it if the animal is available for observation and quarantine. If you are doubtful or unknown, then you start the post-exposure prophylaxis. This will be almost same here also. So you'll start the post-exposure prophylaxis. If was the animal provoked to bite or scratch, in that case, that means the animal did not do it on itself, but it's done as a protective measure. In that case, you can discontinue. So if it came and has bitten the individual without any provocation, that's a risk factor. So in that case, you have to start the PEP. So what do we give for post-exposure prophylaxis? So IM dose, you can give 5 dosing, 0, 3, 7, 14, and 28 days in deltoid, or if it's a child, we go for anterolateral thigh in small children. Intradermal regimens. So they use much smaller volumes, like 0.1 ml per dose per site. So at multiple sites per visit. So sometimes you give 2 sites on each visit. So 2 sites at 0, 3, 7, and 28. So as specified in the national guidelines to reduce cost while maintaining immunogenicity. So if someone was fully vaccinated previously, so after a new exposure, you can give 2 booster doses only, 0 and 3 doses, either IM or intradermal. So immunoglobulin is never recommended if someone was already vaccinated. So whether it's pre-exposure or post-exposure, they need only 2 boosters. So this is as per WHO. You can give immunoglobulins and vaccines. So if it's vaccine intradermal, you give 2 sites on these 3 days. Immunoglobulins only one time on day 0. If someone this is for new patients. The patient was never vaccinated. So if the patient was previously vaccinated, like if the full PEP was under 3 months ago, nothing is required. If it's more than 10 years from last tetanus shot, you give a tetanus. But otherwise, vaccine you give intradermally on 0 and 3 days. Or if you want to give only in one visit, you can give 4 sites intradermally on 0 day itself. So for all category 3 exposures, or if someone is immunocompromised, in them even category 2 exposures require immunoglobulin. So coming to types of immunoglobulins, we have equine, that is 40 units per kg, human 20 units per kg, human monoclonal antibodies. These are 3.3 international units per kg. So when you're giving antibodies, make sure you give only the specified maximum dose. Do not give more than that, because when you give too much of dose, it can actually make the vaccine less effective. So it should not exceed the maximum dose. It can blunt the vaccine-induced antibody response. So timing, it is generally given only once, ideally within 7 days of starting the vaccine. Beyond that, you are not supposed to give. So if someone says, I had a dog bite 10 days ago, 8 days ago, you're not supposed to give. Under 7 days only, you have to give it. The sooner, the better. So when giving immunoglobulins, you have to thoroughly infiltrate large and multiple wounds. If there are more wounds and the dose you have is say like 2 to 3 vials, that is not enough. In that case, you can dilute those immunoglobulins with saline and make sure to infiltrate every wound. So infiltrate maximum possible within the wound and around the wound. And anything that given left is given generally at a distant site. That's not proven to be much beneficial. So most of the immunoglobulins should be given locally, making sure you don't cause a compartment syndrome locally. If it's a small wound, so you can give rest of the dose as IM as close to the as possible to the presumed exposure site. So if someone had a bite over forearm, you give it deltoid, that's fine. If mucosa was involved, in that case, you have to rinse that part with the immunoglobulins. If it was an aerosol inhalation, like say someone is working in the laboratory with the rabies virus, and if you think that the person has inhaled, in that case, you can go for intramuscular route. Coming to hepatitis B. So protein vaccinations we give as part of pentavalent vaccines. So whom do we give them? Like general childhood vaccination and healthcare workers who are at risk. So in them, we tend to give. So in pentavalent vaccine, it's part of it. So all infants and children are given as part of routine immunization. Healthcare workers and occupational exposure risky people will be given. And any household or sexual contacts of HBsAg positive people are also given. Like risky populations, like people who inject drugs, IV drug abusers, those who have multiple sexual partners, and people in correctional facilities like jails, and who need repeated blood or blood product transfusions or hemodialysis, all those people are at risk. So they should be given prophylactically. So pre-exposure prophylaxis, you can give, there are two kinds of dosing available. So recombinant hepatitis B vaccine is given IM, deltoid in adults, and antilateral in infants or young children. So 3-dose schedule 016 is given. In adults, typically we give 20 mcg per dose. In children, 10 mcg. So if it's a child or infant, we give a birth dose, that is ideally within 24 hours after birth, followed by any additional doses as standalone hepatitis B or as part of pentavalent vaccine. So if someone is in a hurry, like they cannot wait longer, there is something called as accelerated regime available. So there are two dosings available for accelerated: 012 and 12-month schedule, 07 21 days plus 12 months. So these two are accelerated regimens. So once the healthcare worker is vaccinated, so testing is usually reserved for high risk groups. Someone is healthcare worker now got exposed. So in that case, we check their titers instead of giving them again either a vaccine. So if the antibody titer is more than 10, in them it is considered as protected. So such people are presumed to have protection from the virus. So in immunocompetent adults, routine boosters are generally not required once a primary series is completed. Although selected high risk or immunocompromised groups may need periodic testing and additional doses. If someone's immunity is intact, they don't need periodic boosters, but others might require. Coming to hepatitis A. So pre-exposure, not universally recommended in India, but advised for specific groups like CLD, travelers, homosexuals, people who use illicit drugs, and those who are at high risk of hepatitis A exposure or severe disease. So the schedule depends on which type of vaccine it is available, like monovalent or combined with A and B. So hepatitis A and B together are also given. So, but typically only 2 doses are given, 6 to 12 months apart. As per CDC guidelines, hepatitis A vaccines, the first dose is part of routine childhood schedule, like half ml. In adults, 1 ml. So combined hepatitis A and B is available for adults aged 18 and older in a 3-dose series, 0, 1, 6. So if someone is traveling, they cannot wait for longer. In such people, you give 4-dose accelerated regimen we have discussed in the previous slides. So all these doses are given IM. What to do if there is a needle stick injury in your hospital? Step 1, encourage the bleeding. Don't try to stop the bleeding. And that doesn't mean you encourage by pressure. You should not be squeezing the part to make it bleed. If it's bleeding by itself, let it bleed and wash with soap and running water. So don't rub too much. Don't use too much of force. No scrubbing, no use of bleach. Don't inject anything into the wound. If it's a mucous membrane, you have to irrigate with clean water and normal saline. Remove any contaminated clothing and keep washing the affected skin. Now, time to check the source. If the source is positive, then the healthcare worker needs to be concerned very much. So, if you know that the source is negative, then you can be at peace. Otherwise, you have to get it tested. So, you have to check the patient who is the source of that needle. So, you have to test them with HIV, HPV, and HCV status. But you have to take their consent. So if testing is possible, in such cases, you go for testing. Coming to exposed worker. So you have to document their vaccination, like what are all the vaccines that healthcare worker has taken, their immunity status, titers, renal function, whether the patient is pregnant or are they taking any current medications, and when this exposure has occurred. So all those things you need to raise an incident report. Coming to HIV. So in this, after needle stick, if it's been less than 72 hours since exposure, if the source person is known to have HIV, then you start the prophylaxis. If you don't know, you'll have to determine case by case. If it's been already more than 72 hours, like more than 3 days, post-exposure prophylaxis is not recommended. Or if the risk is very negligible, in that case also not recommended. So what is the negligible risk? So exposure of vagina, rectum, eye, mouth, or other mucous membrane, intact skin or non-intact skin, or percutaneous contact with urine, nasal secretions, saliva, sweat, or tears, if not visibly contaminated with blood. As long as blood is not involved, then it's called as a negligible risk. Even if the patient is HIV positive, known or suspected HIV positive, in them also, if the blood is not involved, you call it as negligible risk. If visibly contaminated with blood, then it's a substantial risk for HIV. So what do we give? In them, you'll have to start the post-exposure prophylaxis as soon as possible, ideally within a few hours. Don't delay it more than 72 hours. This should be known to all of your nursing staff, especially, and educate them on this. Some people are afraid of those incident reports and all. They do not raise it to you. So if all those IMRs working in your EDs and all, they should be educated on this. If there is a needle stick injury, they should not neglect it. So what do you give? So you have to give a 3-dose antiretroviral regimen for 28 days. So you have to check with your local guidelines and do a baseline HIV test now. you may have to repeat it at 6 weeks, 3 months as per your local protocol. Because sometimes there could be incubation period, window period, all those things you need to consider. So coming to which regimen to go for, there are two regimens available. So depending on what your infectious disease team tells you to go for, you can either choose the left one or right one. So in this, we give three medications like tenofovir, emtricitabine, or plus one of these, raltegravir or dolutegravir. When it comes to alternative regimen, we give four medications: TDF, emtricitabine, that is TDF is tenofovir, darunavir, and ritonavir. So when do we go for alternative regimen? If there is a HIV resistance to the preferred regimen, or there is a toxicity risk with one of the drugs in such patients, or there is local inavailability. So in the such case, if these drugs are unavailable, you go for the alternative regimen. So post-exposure hepatitis B, how to determine whether someone needs something. So healthcare worker status you see. So documented responder after complete series. The patient, the healthcare worker was given full proper vaccination. In that case, and the healthcare worker has enough antibodies. So in that case, no action is needed. Whether the patient is source is positive or not doesn't matter. Nothing is needs to be done because the healthcare worker is protected. So the worker was given entire dosing after two complete series. Non-responder means their immunity levels are less than the recommended dose. In such cases, if the source is positive or unknown, in that case, then you will give two immunoglobulins 1 month apart. So vaccines you have already given, so vaccine is not required now. Only immunoglobulins for immediate protection. If the source was negative, nothing is required. Now, the healthcare worker response is unknown after complete series. Complete series is given, but you don't know whether the antibodies are formed inside or not. If the source is positive, you give immunoglobulins and one dose and initiate vaccination. And post-vaccination, you again do serological testing to check antibodies are being formed or not. If the patient source is negative, then you initiate the vaccination. If there is any type of result, like in case of any result, if the patient's antibody level is more, just like a responder, in such cases, nothing needs to be done. Only if it's less than the recommended numbers, you give vaccination plus then you give immunoglobulin if the patient is positive. If the patient is negative, immunoglobulin is not required. So sometimes your staff is not immunized, or they are not a believer of vaccination. They don't want vaccination. In such cases, as the patient is positive, if the patient is positive, you have to give immunoglobulins and complete their vaccination and check their response later. If the source is negative, still they will have that risk in future. So you have to complete their vaccination. Immunoglobulins are not required. Then for every healthcare worker, you have to check their response and document their anti-HPS levels. So if someone is incompletely vaccinated, so under 24 hours, you have to try to give immunoglobulins if their immunity is not adequate. Coming to hepatitis C, we don't have a known post-exposure prophylaxis for this, only prevention. So both source and exposure worker may be tested. If they turn out to be positive later on, you'll have to refer for antiviral treatment if seroconversion occurs. So this is all that is part of your post-exposure prophylaxis. If there are any questions, I'll be able to take now.
Yeah, that was a very good and detailed session by Dr. Naveen, sir. These are the conditions we routinely see in our ED, like trauma, animal bites, is being our we healthcare professionals exposed to hepatitis and HIV. So
Yeah.
every ED physician need to have this knowledge. And
Yeah, the TD part was actually even new to me. So when I was preparing for this talk, I came to know that the IAP recommends TD instead of plain tetanus. So we have been started advising our internal ER team to go for TD instead of plain tetanus for all the cases.
that is in fact a good information. Even we try to practice in our ED as well. And in most of the conditions, there is no cure, like tetanus, rabies. We don't treat properly, we will lose the patient. So
Yeah, when it comes to rabies antibodies, as they're costly, some people tend to just avoid it. But in at least in Hyderabad, in Narayanagoda, there is a facility wherein they give immunoglobulins. So we can send such patients who are not affordable to such facilities. Even most of the district level hospitals will have a stock of that.
So many people are not actually aware of that. Like vaccine is provided free in the government
Mm.
hospitals because these are not provided in the routine government hospitals. People know, if they go to Usmania or Gandhi Hospital, like those kind of hospitals will not be having these vaccines. So it is specifically provided at IIPM, Narayangoda, that Institute
Mm.
of Preventive
Yeah,
Medicine.
even I used to think that it's available at only at Narayanagoda, but recently they have given at Kondapur district hospital. One of our maids, family member, was affected, so we asked them to not neglect, go there and let us talk to the doctor over there. Of course, they didn't talk to me over phone, but they said they have injected around the wound, so that's when I figured, okay, they have given immunoglobulins.
Okay. So now we'll open the platform for the audience if they have any questions. I don't think we have any audience here. Anyway, I have a question for you, sir. We actually see, apart from the dog bites, we routinely see the cat bites, monkey bites coming to our ear. Which because the Usmania campus is very close to Secunderabad and there are many monkeys over there. So people come with monkey bites. And is it rabies vaccine indicated in those kind of animal bites?
So in this, the WHO has actually given an MCQ, FAQ type of thing, both for patients and healthcare workers. So why vaccine is given and can we give it in gluteal area? So in this, some of them are surprising, like gluteal area. For that, they say vaccine would not be fully absorbed and effective because of the fat present in the body part. So gluteal area is not suggested. So these are all something new. I'll share with it. Only the dogs and bats are the high risk animals, but rest of them need not be given.
Okay. Okay, sir. Uh, as there are no questions, we'll try to wind up the session.
Okay, fine.
Thank you very much for your time, sir. Precious time to enlighten us with the pre and post exposure prophylaxis in this dreadful diseases.
Okay. You're
Thank you.
welcome.